Hello and welcome to another episode of Teaching Heroes, the teaching podcast where I ask educators, what does it take to turn up every day to teach tomorrow's leaders? And today I'm continuing my COVID-19 pandemic in Australia podcast series, and I'm interviewing the incredible Professor Sharon Goldfeld, who's come here to talk to us today about kids and COVID-19. And we're going to talk about kids' health in the whole of it, physical health, mental health. And we're about to, in New South Wales and maybe in Victoria, open up our schools again. And I know a lot of parents and teachers are quite anxious about what does that mean for our unvaccinated population. And so I really just so appreciate you coming on to the podcast, Sharon, and answering my questions and the questions of teachers and parents that I know.
Pleasure.
Excellent. Okay, so can we just start? Can you just tell everybody about your expertise, where you are now, and also some of the research that you've been involved in with COVID-19 and children?
Absolutely. So just to give you a bit of background about me, I'm a developmental paediatrician and a public health specialist. That's my kind of background. I head up something called the Centre for Community Child Health, which is a centre of both the Children's Hospital and the Murdoch Children's Research Institute. And we're focused on younger kids, and we're particularly focused on inequity. So we focus on prevention and inequity and around child development and behaviour. They're the kind of things we focus on. So a lot of my research around COVID has been looking at what we call the indirect impacts of COVID. The mental health impacts, the impacts on parents, the financial impacts, and how that plays out on our understanding of what's happening to children. And what's been really interesting is how substantial those have been, but we'll talk about those a little bit later. I also head up population health at the Murdoch Children's Research Institute. So again, very focused on populations and prevention.
That's great. And again, I appreciate it. And I think that your expertise in population health is, I think, really important here. And I don't know whether the general public get that particular expertise. So can you just explain, what does that mean to be a population health expert, particularly when it comes to children?
Well, you'll be pleased to know that in population health, we use epidemiology. So everybody knows what epidemiology is now. And in theory, I do have epidemiology qualifications, and I thought, no, I'm not going to go out there and be an epidemiologist. But pretty much everybody is.
There's a lot of attention on the epidemiologist, so you have to pick your
Yeah, I know, it's like, oh, but population health is really. So I always like to say, look, I'm a clinician. So as a clinician, and so my specialty is children who soil and wet themselves. That's why, as a developmental paediatrician, And so the N of one is still really important. And I think for many of you, you probably have practitioners who are in your audience, be they educationalists or other professions. So the N of one is still important. What I do with that child and that family is important. But even if I were able to see every child every minute of the day, I wouldn't make a difference to the population of children. And so population of health is understanding the sorts of things, understanding the patterns of health. That's mental health, physical health, social health, understanding those patterns across the population and how they are distributed across different groups, be they high income, low income, rural, metro, Aboriginal groups, immigrant groups, etc. So understanding those patterns, and then understanding what are the sorts of things that we can do that might impact the population as a whole. So whereas you might want a clinical intervention might be about giving somebody a pill, we're interested in population interventions that might impact lots of children at once. So that's kind of what population health is about, understanding how populations work. And in this case, we're interested in populations of children.
Yeah. And I can imagine, is there a sense that some of the things you would have been saying for quite a number of years about social inequality has just been laid bare, so obvious to people in with the pandemic, particularly in places like Western Sydney and its equivalent in Melbourne. Is it Western Melbourne or is it Northern Melbourne?
It's Western Melbourne. It seems to be everywhere on the East Coast.
It's the West. West is best. Yeah, so you would have been saying this for a long time and around the inequities, and now it's just so obvious to people where those social inequalities when it comes to health. And that's who's been hardest hit with the COVID-19 pandemic.
Yeah, and you can see how they're also geographic, these inequities. So we talk about these different inequities, and I'll just be a little bit of a definitional pedant for a moment and talk about the difference between inequalities and inequities.
Okay, great.
So inequalities, when we talk about inequalities, we're basically talking outcomes that aren't necessarily mutable. Like some inequalities, like some people are tall and some people are short. That's an inequality, right? It's a difference, right? But inequities are actually about what we would call preventable inequalities, and they're normally mediated through either social or geographic or other sorts of means. So we can talk about service inequities, so the differential availability of services. We can talk about geographic inequities, so where you live kind of makes a difference. And that gives us a hint about the sorts of things that we might want to do if you understand those geographic inequities, or you understand those service inequities that might lead to some inequalities that are preventable. So that sort of stuff we're very interested in. You're right, what we're seeing are these geographic inequities. So where you live makes the difference in Sydney and in Melbourne. So it is absolutely, COVID is laying bare those inequities. But what it's also laying bare is it's clear that some kids are getting great remote learning, some kids are not getting great remote learning. There's clearly a financial impact on a lot of families. So we're talking about COVID kind of opening the cracks, remembering that the cracks were already there. And I think what COVID will do, not just expose the cracks, I think it will open them.
Yes, and it's I've been talking to the Deputy Head of Nursing actually, and we've been talking about nurses and teachers and the impact of the pandemic on both of those professional groups. And the metaphor we used, we said, what were once cracks are now gaping wounds, you know, and really need an intervention, a serious intervention now, I think, in both those professions, and then in as you're seeing in the work that you're doing with children too. So when the pandemic first hit, was there equal impacts, do you think, from the beginning, or straight away when we went into lockdown were those inequities, present straight away?
Yeah, so I mean, the pandemic is a kind of universal, let's call it intervention. Yeah. So it happened universally, but actually how it translated was totally inequitable. So if you think about the pandemic, forget the public health lockdown, but even the fact that there was this pandemic coming, if you knew you were in a good home and, you know, you've got everything around you, you're going to react different to that, what one would call an existential threat, quite differently to different homes. And then layer on top of that the public health restrictions that already very early on, and then of course the public health restrictions and everything that came out of it, which is loss of jobs, all the rest of it. So very early on you would experience the pandemic in a very different way depending on your circumstances. And some people have, you know, gone through okay, you know, across the social spectrum. You know, if you're well supported, lots of people will have like, I don't think we should underestimate resilience. But at a population level, so the individual level, you see lots of variation. At the population level, you see these kind of fundamental patterns emerging.
Yeah. And can I ask, has your research been predominantly in Melbourne, or is it Australia-wide? So it depends what research we've been doing. So we've been doing a few things. We've been following up existing cohorts that we already have, so we understand what are the risk and protective factors for how kids are doing in the pandemic. That's predominantly Victorian cohorts, but what's really interesting about them is it's rather than what we call cross-sectional, just a point in time, we can actually say, well, these people aren't doing so well, but actually beforehand they were or they weren't, or what are we learning based on previously that tells us something specific about that pandemic and the risk and protective factors. So that's the beauty of these cohorts. Wow.
But then on top of that, sorry, go on.
Sorry, I'm so interested now. What is there any research that you can share with us now about those?
So there's a few cohorts. In fact, I've just presented on this. So one is a cohort that I'm involved with, so I can talk about that with more certainty, which is called Right at Home, which is a sustained nurse home visiting trial. So we did a randomised control trial where the maternal child health nurses, or family child health nurses as they're called in New South Wales, went into people's homes for families who are at risk. So they were all, these women were all living in some level of adversity, quite significant. Now, you know, 50% of them didn't have a job, and then worked with them around really helping them be the parent that they want to be, and then followed them up. And we've just followed them up now to 6 years. And so they just happened to be, you know, during the pandemic. And so for those families, what we found was they did much worse. So they were, so 50% already weren't employed and another 40% lost their jobs. So we're seeing financial stress, mental health stress, lots of worries about COVID, even though only one person actually got it out of that whole 700 women, one person got it.
That's crazy considering your numbers in Melbourne.
This was back in the 2020 days, not in 2021.
Yeah, right.
So this was back in the good old days when we had Alpha.
Where your top was 700 cases a day. Oh, how we long for this.
Yeah. Well, no, we don't long for that in Melbourne. We're not there yet.
Yeah.
So I think there's so we're definitely seeing the in differential impact. There was also some lovely things. So families who were well supported did better. Wow. But we certainly saw this kind of really sort of major sledgehammer sort of effect, I think. And this is taking into account from the mental health point of view. So 50% of them had distress, but that's taking into account their previous mental health. So that's what we can do, because you can say, well, maybe they were always distressed, right?
Yeah.
But that's even taking into account their previous mental health levels. And then from another study called the Australian Temperament Study, which is 3 generations, what we saw there was, again, this kind of differential impact on lower income, but some protection in that cohort of job keeper and job seeker. So that was really interesting. And then we've got a study that's following up adolescent children of women that we've been following up for a long time, where kind of 1 in 4, 1 in 5 have got some suicidal ideation and self-harm. And that fits with our looking at presentations to emergency, where kind of self-harm's gone off the scale and eating disorders have gone off the scale. Not much else though, maybe a little bit of an increase in anxiety, but the 2 biggest ones are self-harm and eating disorders. Eating disorders has gone off the chart
really?
across the country, regardless of whether or not you're in lockdown. Worse in lockdown areas, but it's not like Perth doesn't have it. It's really, really interesting.
What would you count as eating disorders? Because there's lots of jokes around people, Uber Eats and alcohol.
No, I mean mainly girls, adolescent girls losing too much weight and needing to be admitted. So it's very unusual with an eating disorder to have to actually get admitted. So, and because they're losing weight quite quickly. So nobody really knows a reason for this. It's, a good question, whether it's a control issue, too much time without friends, too much time in front of social media. Nobody really knows, but it's a definite phenomenon. It's a phenomenon actually around the world, which is kind of really interesting. And then other data that we have, which I think it'd be worth talking about, which is our national data that we have, something called the Royal Children's Hospital poll. So the poll's been running for maybe about 5 years. It runs intermittently, asks parents across Australia, about 3,500 parents, a whole range of questions. But during the last 12 months, we've been able to ask parents about their mental health, their kids' mental health, and their financial distress about 3 times. And it's an interesting natural experiment because sometimes Melbourne was in lockdown and the others weren't. And then in July, New South Wales and Victoria were both in lockdown. And the parent level distress went through. It was 60% of Australian parents were saying they were having mental health distress.
Hands up over here.
Yeah.
Still occurring. Yes.
And there was more in single parents and more with parents with younger children, for all the reasons you can imagine. Why? So it's a pretty real phenomenon. Some of it will go away. Early childhood has been closed in Victoria, but once parents get back to more, I know it's been sort of on and off in New South Wales. Once schools get back, once we get back to a rhythm of normality, a lot of that stuff will melt away, but not all of it. And in particular, not everybody will have a job at the end of it. So I think that's the challenge.
Wow, I have to say I'm a bit overwhelmed. I'm actually a bit close to tears thinking about all those teenage girls sitting at home by themselves. And I think you're right. I think it must be about control. That's my kind of instinct, is that's the only thing that they control in their life would be food intake. And so anything else was just really taken away.
It's so fascinating. Because, I even speak to people in their 20s, young people in their 20s, and they're really feeling it, this kind of lack of, they're supposed to be on job pathways and partying and, and so what pathway are you on when, your job involves you sitting at, the very thing that people want in their 20s is to be with other people. That's why, of course, it keeps taking off in the 20-something-year-olds, because, in the end, that's just the animal that they are mostly.
Yes.
So it's really not surprising, isn't it? This kind of, and that's mainly obviously in the lockdown states. I think I don't know if people feel quite that way in West Australia and Queensland, but they also can't do the other things. They can't travel and do the things they would normally do.
Definitely found that at a university level. It's like an experience from first year students that they don't, it's the students that are going from first year into second year are saying like they don't have any friends in the cohort because they haven't met, particularly in Melbourne, they haven't met their colleagues, like they haven't met their fellow students. So what would have once have been a transition from, say, your high school friends to maybe a university friends, network, that they just haven't had that. They haven't had that experience of meeting fellow students.
And I think it's interesting as I've had two kids both go through university, and what's really interesting is not that they hung out there all the time anyway. I was a bit, as somebody who didn't grow up with the internet during university, you had to go. It was like you went or you didn't go get it. It wasn't recorded or any of those things. And so you ended up being much more on campus. And I was a bit shocked by how little they were on campus. But now I realise even that small amount was enough to connect to other people and to connect with other people on campus, and that there was that choice. Whereas now, and it's really hard, and Zoom doesn't cut it.
Yeah. And so we kind of get to this current pandemic, and your voice and other voices of researchers and scientists that work with children and young people. I can hear that your voice is in, really trying to get through to the general population about the impact of mental health on children, and along with that, talking about I was going to say low impact. I don't think that's the word. It's not as serious. COVID-19 isn't as serious. SARS-CoV is not a serious disease as it is for adults, and so that there needs to be a bit more nuance in policies. So, could you talk to that about what's the actual physical what's the word? Physical impact?
Yes, that's right.
On children.
So I think it's worth just sort of saying that this is not a kind of sum zero process. So it's not like it's all mental health and no COVID, and it's also not all COVID and no. So there's this kind of non-sum zero balance of costs and on opportunities, and so that sort of balancing is really serious. And so every parent in Australia at the moment is doing that balancing act in a way they weren't doing 6 months ago, which I think is really interesting. So it's always been clear to parents that their children should be at school. Yes. There are a few children who really like being at home, but in general, from the parents' point of view, and in Victoria, the closure of early childhood education care, it just cripples the workforce, and I can say disproportionately affects women. And so that's the other little agenda that's kind of slipping away here, is it disproportionately affects women and feminised workforces, but that's a separate conversation. But
different podcast, maybe, Sharon.
Different podcast, and I'm not an expert in that, but that is actually what we're seeing, of course.
Yeah.
So what's happened over the last few months as Delta has arrived, it's really changed everything. Whereas with Alpha, back in the good old days, we really saw almost no transmission between children. I mean, even weird things happening where they would really not have any symptoms or not even have it, even though their parents had it. So just nothing happening. And so much more comfort about, what we're doing. And mostly parents, there was really almost no impact of the virus itself on children. And in fact, most parents, adults who were getting it weren't that sick. And yes, you might be might have lost a grandparent, but actually a lot of those people who were dying were quite elderly. So not that that's absolutely not sad for that family. So I'm not negating that, but for the majority of families out there, there was very little impact directly of COVID. Massive impact of lockdowns, of course.
Yes.
With people losing their jobs and not being, all of the things we already know about. Along comes Delta, and two things changed. We got a vaccine and we got Delta at the same time. And so two things happened. First of all, vaccine became available for adults. Then we had the whole AstraZeneca debacle. So then we had this kind of weird lack of vaccine uptake during the window where we could have probably vaccinated much higher. And then there was COVID in kids. So whereas previously we hadn't seen COVID in kids, with Delta, we saw COVID in kids. And what we saw is exactly what we see in the Northern Hemisphere, which is reassuring, which is that in essence, in kids, it is a mild disease. It doesn't mean kids never have serious illness. So we probably think maybe 1 to 2% of kids might be hospitalised. We don't know exactly in Australia because a lot of kids in New South Wales are hospitalised for social reasons. We have a whole heap of children whose parents are too sick to look after them, so they end up in hospital, they're well, absolutely well. So some kids will get really sick, and so we don't want to minimise that. But it's very, very small numbers. Remembering we've got respiratory syncytial virus, another respiratory virus with no vaccine, and we have hundreds of admissions during its peak season in hospital. So parents are used to infectious diseases, right, in their kids. They get them all the time, and mostly kids are okay, which is exactly what's going to happen. And occasionally a kid gets really serious asthma from it and has to end up in hospital. And then even less end up in ICU, but not never. And then we essentially have had no young children die in Australia at all of COVID, but it doesn't mean that nobody in the world has, but very, very rare. So against other infectious diseases, it lines up pretty well, and some of them are even worse, to be honest. That doesn't mean as a parent you're not anxious.
Can you compare it? And I know I don't know whether I'll get slammed for this, because I know, when people say it's like the flu, it's not like the flu. But can you, in terms of impact on children, can you compare it to something? Like, is it like a bad cold?
Yeah, well, the symptoms are, children are either asymptomatic or have cold-like symptoms in the vast majority. There's other symptoms they might get, diarrhea, vomiting, etc. There's a whole range of symptoms kids would get. So, but I can only talk to you from a population health point of view. That doesn't mean as an individual parent with your child, you should absolutely be thinking about this, but also be reassured in some way. Okay, well, even if my kid does get it, they're probably likely to be well. Which is really reassuring. So with the flu, we still tell people to get immunised, children to get immunised. The main reason we tell children to get immunised are two things. Number one, they can get secondary pneumonia, and it's the pneumonia aspects of COVID that we worry about. And also, we don't want their parents to get sick. So you kind of want the parent to be immunised and the child. So it's very similar with COVID. Where we can, we obviously immunise the parent, where you can the child, and that's kind of a view. RSV, which is this one I was talking to you about, there's no immunisation. And we just accept it. So I think there's this kind of, and also it's early days. We're still learning about COVID in kids. So I couldn't sit here and go, don't worry, really, Joe, we've got it all sorted out. And, I think we're learning. But we should be optimistic and reassured as a population to say, actually, the kids are probably going to be okay. They're certainly probably going to be much more okay from COVID than they are from some of the mental health impacts and lack of access to learning, differential access to learning. That's probably a greater impact for kids than COVID as a whole, which is, I think, reassuring.
Yes. So and I just saw that the UK originally weren't vaccinating their 12 to 15-year-olds, or it wasn't pushed. Now there is that rollout in that space, and us in Australia just started that. So I was wondering about younger than 12, and I guess in particular thinking about those crossover ages. So I have a 10-year-old who's nearly 11, and me and my husband, we're both vaccinated, and so we're concerned about him getting it. And I accept that it is statistically, if he did get COVID, he would be most likely okay. But I know I've spoken to other people who have, children that 10, 11. And what I wondered was, what is it about children, that makes it a less impactful disease? And less transmissible, and what occurs, in the 12 to 15-year-old age group that makes it more of a serious or more possible for it to be a serious disease?
It's more that it's more transmissible as you get older rather than it's a more serious disease. So that's So what we know with the younger kids, the younger you are, the less you transmit. So the really, really little ones transmit much less than. So everyone's transmitting more with Delta, but relatively, the littlies transmit less than the slightly older, The reason the UK is now doing their 12 to 15-year-olds is because of the transmission. And what ended up happening is it's going back into homes where the adults aren't vaccinated.
Right.
So so what Delta's doing now is really it's the disease of the unvaccinated. And so anybody that's unvaccinated is at risk. So if you have your entire 12 to 15-year-olds unvaccinated and transmitting, because they are transmitting, nobody cares about whether kids get it in the UK. That's not what's driving them. But the high rates, and of course, there is still, if there's high rates, there's still more kids in hospital, because if there's more numbers, there's more kids in hospital. But the fundamental reason was a combination of, we probably don't want 12 to 15s in hospital because we want to use our hospital beds for other things. And we don't want them in hospital, obviously. And then also hitting unvaccinated older people.
So, however, though, wouldn't unvaccinated adults most likely not vaccinate their children? So is it kind of like we want to vaccinate, families that choose to vaccinate, we want to vaccinate the whole family so that there's less transmission to the students, to the children that are not, or the families that have chosen not to vaccinate?
Correct. So that's when we talk about this kind of protective shield, where you won't ever get everybody anyway, but if you get enough people, the virus just doesn't have enough people to go. If you think about just a virus hopping around, well, I can't hop to you, and I don't, it's not quite like that, because of course you can still get it if you're vaccinated. But it's really creating that level of, it's the population health stuff. It's enough of the population to make sense of it, where for the people who are not going to get vaccinated. What you want, though, is the higher is the better.
Yes.
So that's why what they're doing in, and the other thing is, which we haven't talked about, Joe, is that there are still trying to understand what the side effects are from the vaccine in 12 to 15-year-olds. So there's been some unusual side effects called myocarditis, which is an inflammation of the heart muscle. Rare, but common enough for someone to go, we need to watch this. So the UK is doing one shot of vaccine. Wow. So they're doing one shot, which is enough to give people decreased transmission and give them some coverage, but decrease hopefully some of these side effects. So interesting to see what happens with that. So these are the kind of costs and benefits that people are thinking about.
Yeah, and is that for both vaccines, for all vaccines? They're just doing that.
Well, particularly it's only Pfizer that's been given to it's only Pfizer and Moderna that are given to the young kids.
Yeah, and then just one shot. Okay.
Yeah. Okay. And then there's testing in the younger. But once again, one's going to have to weigh up the safety and efficacy against potential benefit. So there's going to be a lot of thinking about that in terms of, for a population that's essentially pretty much well from the virus, what will happen with the vaccine and what are the benefits of that. So I think there'll be a lot of thinking about, how big a rollout do you do with the primary school kids, and then the less than primary, I think there'll be even less appetite to do it.
Yeah, I'd like to talk about that a little bit more, because I think there is angst, and I always try and think, my Twitter world and my real world are quite different things. There's so much more angst on Twitter than there is in the real world.
That's a good thing.
Yeah, I think so. I remind myself often. But there is, definitely conversations between my friends who do have primary school age children about the fact that their schools are about to be open to unvaccinated children. And so they're concerned about now exposing their children to the virus. And so what is it that we're doing as in terms of population health to protect the children that, I can see most children will be a mild disease, but for some it might be quite critical.
Yeah, but very few. I mean, very rare. Yes. So I do want to emphasize, I don't want to minimize it, but because I do understand where parents' minds go, because I'm a parent myself. But working out individual risk around your kid is always a really, really complex thing. But every time, when you don't have children old enough, and let me tell you, when they get in a car, that's when your heart.
I'm really praying, Sharon, that electric or driverless cars come in by the time my 10-year-old.
You'll still have your heart in your throat, because they'll be out and about. And what do they do anyway? That's just another podcast. But in terms of that, so I think we have to be mindful that this is also going to need some layered mitigation strategies, what we're calling layered. So in other words, what we're hoping as schools open is there are a number of things will be in place. So first of all, we're hoping most of the parents will be vaccinated. Remembering it's adults who are transmitting this disease predominantly, not children. So the adults in the children's lives. So that means the parents, the grandparents, the cousins, the aunts, the uncles, any parent that you can get, any adult you can get hold of should be vaccinated now. Then the next kind of layer is the teachers and the staff. And that's already starting in New South Wales in earnest. It's been mandated, in fact, in New South Wales, which is kind of interesting. So that's the next fundamental layer, because remember, the adults are the transmitters. Then there's all the layered mitigation strategies go along with that. So don't come to school if you're unwell, masks, no one hangs out in tea rooms. Look at simple ventilation strategies, opening windows, opening doors, do more outside. You don't want to fry kids outside, but do more outside. Maybe not every kid has to come, maybe not every class has to be there every day. So maybe to start with, it could be I'm just trying to New South Wales system, kindergarten, grade 1, grade 3, grade 5, you know, or kindergarten grade 1s and then 2s and 3s on Tuesdays. And it's not perfect. It doesn't get rid of remote learning, but it kind of gets us back in a measured way. So that's another mitigation strategy. Masks on teachers, another mitigation strategy. I think the jury is out on masks on children less than the age of 12. WHO recommends it, but not compulsory. So that's kind of our view. Maybe the grade 5s and 6s, but maybe not below that for all the obvious reasons. If you've got a young kid trying to think about keeping a mask on them.
My 10-year-old wears a mask for fun, like, you know, not for
he
wears
I think
it's like all over. He's like, it's pointless.
So those are sort of things that we kind of go, maybe, you know. And then there's simple things like, you know, hand washing and really reinforcing that. And then what I call the click and collect version of schooling, which is parents drop off and then you collect them at the end of the day.
Kick out the car door. No.
Yeah, you know, so you've got less adults. And then it's the adults that are the issue. The adults are the high transmitters. So all of those mitigation strategies. So I don't think any of us are saying, don't worry about any of that, just send the kids back. I think parents should be really reassured, well, there are all these mitigation strategies. And when you put all those mitigation strategies, if you look overseas, say it, even Singapore's a really interesting comparison because they've got what we have, which is a relatively naive population, because most kids haven't been exposed to it, whereas the UK, we think probably heaps of kids already had it at some stage. And they're not, and with all these mitigation strategies, they're seeing few outbreaks. I mean, you will see them. This is not going to be nirvana where we have no outbreaks. We will see them, and we'll have all the painfulness of tracing and doing all that stuff. It will happen, but hopefully not as often as we'd like. We have to sort of give it a go, and hopefully with as minimum impact as possible on kids. But I do think for parents, it's really important to have a think about all those strategies that are going, that are kind of all the protection layers around their kids and around the adults. And their role as parents, by the way, to be vaccinated and to make sure everybody else is vaccinated.
Yeah. Were you surprised when they mandated it for teachers? I was surprised. I didn't think that was going to happen.
Yeah, I was surprised because I know, you know, I know the teachers union would have pretty strong views on this. I think it goes, and I don't know the situation in New South Wales well enough to know, but I haven't heard a lot in the media from the union. So I think most teachers would probably like to know that when they went to school, it's no H&S issue really.
Yes.
They would like to know because it's adults to adults, remember. So kids aren't really going to give it to adults. Adults will give it to kids, but kids don't give it to each other very often, and they certainly don't give it to adults. So they're not the problem. The problem is the adult to adult. So you'd be good to know if you were going to work, wouldn't it? That pretty much everyone's had at least one shot, maybe not two, but at least one shot. That's going to dampen down all that transmission. I think you'd want to know that, wouldn't you?
Yeah.
So I think that's why teachers are kind of accepting it.
Yeah, I think that's a reassuring message. I just want to bring out again that teachers, you know, because it's in New South Wales context, and I know there are some schools in Melbourne that have mandated it for teachers that have come out in the press, although it's not a statewide mandate at the moment, but that they can be reassured that just because they're going to school with children who, in the primary school in particular, children who are unvaccinated, they should be reassured that all their fellow teachers are vaccinated, and therefore they're protected from serious disease, and the likelihood of transmission in between adults is like rare,
But
almost none.
Just remember, not just the vaccination. It's don't come to school if you're sick. Get tested, wear a mask, and I say that not just to be a pedant, but to say that all of those things, what we know is that the layering of those strategies are really important, and just building that into, well, if we know we're all vaccinated, we know when to wear masks, we're washing our hands, we've kind of got some stuff we're doing outside, we've got staggered lunch times, all of that stuff, at least in the short term, until our double vaccination rates are up around over 80%, and then we're in a different world.
Yeah. So what should happen then, do you think, hitting 80%? What's the talk then, particularly in regards to, say, children or measures for children? Because part of the mental health, and I was very outspoken when they on Twitter, which is just will have amazing impact, but but the closing down of playgrounds in Melbourne, I just was so shocked by it. And because what I do see sometimes is that there are some very vocal Twitter journalists who get on the New South Wales must do everything that Melbourne do, and we're starting to call in press conferences every day about why aren't your playgrounds closed. And as a parent, I was like, shush, like that is the only joy my kids are getting, is us walking to the local playground and they play on the swings for an hour and then we come home. Like that is like our lifesaver. And to close it down, it's just, that's.
So a couple of things. I wrote about this in the conversation, actually. So we actually looked at the evidence about transmission in playgrounds, and there wasn't really, first of all, there's almost no evidence of it under Delta. So it was pretty hard to say too much, but not really kind of any kind of good evidence to suggest that a lot of playground transmission happens for kids. The issue is the adults. So it's the adults hanging around, talking to each other, masks down, having coffee, cocktails, whatever else. And so that was the issue. So that's why they opened up playgrounds again and then said only one adult and all of that sort of stuff. But it was the adults. It's not
kids.
It's not the kids. So that's why playgrounds are back. Thank goodness.
And I think my experiences was that most parents were quite risk averse to talking to each other too closely. So you might run into someone will say hello to a parent, but that the distance is there, everyone's got their masks on, and it is really just the children that are kind of playing. But I do accept that there is always parents that take it a bit too far, so I can understand it from that point of view.
Don't we all miss being hugged, though?
Oh my gosh. Yeah.
That's what makes me teary. I think I was watching something on TV and people were hugging, and I kind of got a bit teary. I thought, I'm a big hugger, and I don't hug my friends anymore.
My son, we were watching a show and someone hugged and he goes, "No, coronavirus."
I know sometimes you have this reaction. Are you allowed to do that? Okay, it's only a TV show.
Yeah, that's right. Where's the masks? That actually just makes me wonder about teenage girls as well, because they're so physical, and boys too. I have to say, as a teacher, boys are very physical and touch. They might not hug, although they do that as well, but very physical with each other. And so I wonder whether that's if we're thinking about cutting and health disorders, whether it's actually physical touch of their peers that they're really missing.
I'm sure it's all of that. I'm also saying teenagers ignore all of that, but because I think they just can't help themselves. And I think that's just part of life. But I do think there's that just general change in behaviour that we don't hug as much, we don't shake hands, we don't stand too close. So I think that's what we just have to do at the moment, and that is the public health behaviour that we have to have, even at 80%. That is not actually some magic. Then we'll have to get well over 90% to really remove a lot of that sort of stuff, and then it just becomes our vaccination rates keep going, and then everyone else just gets it, and then eventually it's just an endemic part of our lives, like the flu is an endemic part of our lives. But we're probably a fair way off that for the moment.
So the other thing I wonder about is that those children who are, so what I wanted to ask about, so there are adults who so Aboriginal Torres Strait Islander people with diabetes or with cancer who say maybe can't be vaccinated or haven't had access to the vaccine yet. They're at a greater risk of being hospitalized through COVID-19. So I wondered, in children with those comorbidities as well, are they also more susceptible to greater disease, or is it only in the adults?
No, they are, but not quite the same as the adults. So there's a couple of things. Just like the adults with chronic diseases, we would say children with chronic diseases, where it's possible, should get immunised now.
Yes.
So they are a high priority.
So even under 12?
No, because we don't know. Because once again, you're balancing. There's no vaccine. We don't know if it's safe. It might be safer to get COVID at that age than it is to get the vaccine. So we can't say that. But in the older than 12, 12 and older, sorry. If you have if any child has chronic disease, or Aboriginal and Torres Strait Islander, or really sadly living in a marginal population, get vaccinated now. That they are absolutely a high priority, because they are more likely than children who don't have those to end up in hospital. So not less likely than an adult in the same situation, but more likely than their non-chronic disease, if you like. That was a bit awful. Peers. So they are definitely a risk. And then, as I said, that risk goes down as kids get younger, because they're even less likely to be sick with COVID. But we in terms of children less than 12 who've got really substantial illnesses, that's a kind of, like it is from many infectious diseases for those parents, it's always an issue on how do you protect them, and probably for those kids, when there is a vaccine, they will be the ones that will get vaccinated.
Yes.
Whether it's a whole of population thing, I think is a bit, let's see.
Yeah, so there is that risk benefit, and I think that's a really important point to again bring out, that because in the majority it's a mild disease in the under 12s, we want to ensure that, do we need a vaccine at all for children, and to ensure that if we do decide to vaccinate, that it is a safe one.
Safety issue is really important. That's why the studies have been held up, because they haven't seen enough children for long enough to know. Because, for a mild condition to have a rare side effect is still a bad imbalance. So if you have a rare significant side effect for essentially a mild illness, that's not the right balance. It really has to be pretty much no significant side effects. Then you would vaccinate against what is essentially a mild disease.
Yes, yeah, I can see that. The other thing
at a population level, it's a lot of people, remember.
Yeah. The other thing I think about is also masks and also the testing that we currently have for children. And I admit that I have kept my children, my youngest one, so more my 7-year-old who's anxious already. If he's been sick, I've just kept him, admitting, rather than getting him tested, I've kind of like tested the whole family because of his reaction to that testing. So from a population point of view, then, are there other tests that we could give children that would be less traumatic, or, and I guess we already talked a bit about masks and whether it's necessary or not, or
so that's probably for your 7-year-old, probably hit and miss as to whether you put a mask on them. In terms of testing, so I think we'll move, probably they're doing some piloting already around rapid testing, so that just goes in the lower nose, not the upper bit. So that's a bit less traumatic. And then there's some very groovy ones that are being developed at the Children's Hospital called Rhino something. I can't remember the last bit of it, but they're just kind of little plugs that sit at the bottom here, so they're not really as traumatic. So I think we're seeing more and more. Look, we've been looking at saliva as a testing mechanism as well. It's just not that accurate.
Yes.
So we had this kind of view that kids would come in, spit into a bucket, and you just test the bucket, and But anyway, the good old days, spit bucket. But anyway, so I think those sorts of testing things, they'll probably come in the short term, and then as we get used to living with COVID, they'll probably go away. But they're looking at all those sorts of things, and in particular in schools where they've got a lot of vulnerable kids, like some of our special developmental schools, where you really do want to make sure you don't get COVID in those schools. So I think some sort of asymptomatic screening regularly of the teachers will be really important. But that's all to be sorted out, I reckon. But I think you'll see in the next few weeks a lot more of the rapid testing coming into play as pilots come on board.
The other thing I think about is, like, going forward, how do we, because at the moment, to me, it seems like the community is quite fractious around the impact of COVID, what we should be doing, the different lockdown strategies, do they work or not, safety or not, it's fine, it's not fine. And I wonder about that mental health impact on children, because I noticed when I was anxious about COVID, my kids were anxious. And then as I, managed that better myself, they started to manage and have a bit of a more healthy kind of appreciation that, yes, this is a serious disease. We have to stay home at the moment, but that eventually everything will be okay.
There's some really nice podcasts that we did for MCRI, and also recently this talk at Royal Children's Hospital about the things parents can do to dampen their kids' anxiety.
Yeah.
And part of it is also how you feel as a parent, some of which you can control, some of which you can't.
Yeah.
But also just doing things like switching off the TV when the news is on, talking to kids about what's actually going on, being able to be kind of reflective. Oh, I wonder what you'll talk about to your children and your grandchildren about this, because there is a lot of resilience in kids.
Yeah.
So I think there's lots of things parents can do that can address their kids' anxiety,
Yeah.
but also think about their own anxiety and how they can manage that with their kids. And I say this not saying that it's like a trivial thing to do,
Yes.
but absolutely children are, particularly younger children, are keen into the parents' anxiety. That's why more time with the TV off is probably, all of us are, refreshing news all the time, aren't we, on our phone.
The numbers.
And Jo, I'm going to have to leave you.
Oh, okay. That's fine. You're an important woman. I'm sorry.
Well, it's not so much important. I've just got another meeting to go to.
Well, I just thank you so much for coming on the podcast, Sharon. I really appreciate your time and your expertise. And it's been such a great conversation. And, I'll be certainly following up your research and sharing your research as it comes, because I think it's a really important message that both teachers and parents have to, really weigh up, as you say, that risk benefit for their kids. So,
and good luck, everybody.
Yes, thank you.
Hopefully we'll see everybody on the other side, hey?
Yes, that's right. This has been another episode of Teaching Heroes. Thank you very much. Bye.
Bye.